indications, side by side, you tend to produce some adverse drug reaction. Our first adverse drug reaction that we initially talked about was excitation. Now, the drug is a CNS depressant. It works by producing CNS depression, and via this mechanism, it is able to produce cardiovascular depression, it is able to produce respiratory depression. But despite knowing this fact, it is still producing excitation. Why and how? We shall talk today. Now, this excitation does not mean it is going to last for a longer period of time. Just like taking alcohol as an example, a person who takes a little bit of alcohol tends to enjoy more, talk more, dance more, sing more because of excitation. Similarly, the same is the case with these benzodiazepines and barbiturates. But as the consumption of alcohol increases, then the person starts to lose consciousness, not able to coordinate muscle movement, might go into sleep, and even higher dose can even make him collapse. So that is the same with benzodiazepine and barbiturates. But why is that initial excitation then? To understand this, we need to talk about two of the neurotransmitters in our brain. One is the GABA itself, which is an inhibitory neurotransmitter, and the next is glutamate, which is an excitatory neurotransmitter. In diagram, we can represent this GABA is producing depression, while glutamate is inducing excitation. But if inhibiting this GABA, if we inhibit this GABA, then this GABA, which was initially producing depression, will produce a paradoxical effect, leading to excitation. So here, this GABA initially was producing depression, but if we inhibit this GABA neuron, this will lead to excitation. And this is what we call as paradoxical disinhibition. Instead of producing depression, we are seeing excitation, which is an opposite effect, in other word, paradoxical word. And inhibition of inhibitory neuron is disinhibition. So that is how you end up having excitation with sedative and hypnotics during the few initial phase. Now, like all CNS depressant, this also leads to addiction. That is why any person, a normal person who is not able to sleep, are not recommended these sedative and hypnotics, because consumption of these sedative and hypnotics can lead to addiction. But how long does it take for a person to become addicted to this drug? Actually, from 14 day onwards, there is chances of being addicted. But by the time the patient consumes this drug for 4 weeks, 30 days, then there is high chance that the person will be addicted to this sedative and hypnotic drugs, especially the diazepam drug, and without which he is not able to achieve the same level of sleep. You come to know that the person is addicted to diazepam whenever he shows symptoms of craving, isolating himself from the rest, and continuous use of drug even though the problem is not solved. So this is how you identify addiction towards diazepam. You'll notice bluish discoloration of the lip, most probably due to hypoxia. Hypoxia is because of respiratory depression. If the patient will have double vision because of loss of eye coordination, because of CNS depressant action, he will be having drowsiness, difficulty breathing, weakness, and unable to coordinate his movements. And in case if that patient consumed this diazepam with some other CNS depressant like drugs, for example, alcohol, antipsychotic drugs, opiates, and antidepressant drugs. If you consume any of these drugs with these sedative and hypnotics, the chances are that these drugs will produce supraadditive action, which can lead to collapse due to respiratory failure, collapse due to cardiovascular failure. In fact, there are so many events that has happened till now. Many of the singers have collapsed by taking even minor drugs. Let's not talk about sedative and hypnotics. Just by taking some antihistaminic drugs, probably because they were having cold and they wanted to perform on stage. So probably they took antihistaminic drug, and along with antihistaminic drug, he or she might have consumed alcohol. Antihistaminic drug is a sedative and hypnotic drug. It's a mild sedative hypnotic. And alcohol to a therapeutic level is also a mild sedative. But the combination of a mild to mild sedative can become a very strong sedative action. You'll find plenty of examples of this combination. People taking some antihistaminic drugs with alcohol suddenly collapsed, did not wake up, and so on. And this is all because of the combination of two drugs. In fact, even if you combine two different forms of alcohol, mix whiskey with rum, whiskey with beer, or mix rum, whiskey, beer, vodka, the effect of those combination is going to be even stronger than the individual component. That is how you will get a very supraadditive action. Therefore, whenever a patient is taking sedative and hypnotics, you should never take another CNS depressant, even if it is a mild one, even if it is an anti-cold medication like antihistaminic drugs. Tolerance. Tolerance means in order to achieve that same clinical effect, you will be requiring a higher amount of dose. Now, here you'll observe that the tolerance is only seen with sleep disorders. A person comes to you saying, I'm having difficulty sleeping since 3 months. I'm not able to have good conversation. I'm always in a stress because of lack of sleep. I get very irritated. So prescribe me some medicine. You prescribe him diazepam 5 mg. He'll consume it for 4 weeks, a month that is. Then he'll come back to you and he'll say, this drug is no more acting. I need a little bit stronger one. Then you'll be prescribing diazepam 7.5 mg. Then he'll come back again after 2 months. Then you'll increase the dose to 10 mg. That is what tolerance means. Every time you'll have to increase the dose to achieve the same clinical response. But that is only limited when you are prescribing this drug to induce sleep. You won't find tolerance if you are prescribing for anxiety purpose to produce anti-anxiety effect. The same 5 mg of diazepam will work for 6 months, 7 months, 8 months if you are prescribing as an anti-anxiety drug. So you will find tolerance to sleep disorders, but you will not find tolerance to anti-anxiety effect. Dependence. All CNS depressant drugs will produce dependence, which are of two types. One is psychological and the next one is physical. Psychological dependence is something that you can convince the patient, because he will only have the craving for that drug, craving for cigarette, craving for nicotine, craving for alcohol. By confining him to one room, by convincing him, by distracting him from that particular drug, you will be able to break that dependence. But physical dependence is different. In physical dependence, you will find a symptoms known as abstinence symptoms, in which the patient will be anxious, will be restless, means will not be able to sit at one place, will be walking around in search of something, will have sweating, will not be able to sleep, will get irritated, will be aggressive. So physical dependence can be some challenging thing for the clinicians. And in order to fight that physical dependence, you will have to administer some other drugs to make him less excited, less anxious. So might have to decrease the dose of sedative and hypnotics. Now, are all sedative and hypnotic liable to produce dependence? The answer is no. Drugs which have shorter half-life, they produce less intense of dependence. Produce very much, like the intensity of dependence is very high, but it is very short lasting. But drugs which have longer half-life will produce less intense dependence, but it is going to last for a longer period of time. In other words, there is severe craving for drugs by consuming drugs which have comparatively less intense craving if you are consuming drugs which have longer half-life. Probably because those drugs remain in the body for a longer period of time. Now come to the antagonism section. Here, this is one difference between barbiturates and benzodiazepines. That is, with barbiturates, there is no antagonist. If you happen to get overdose, you cannot reverse it simply. There is no particular drug that can reverse barbiturate poisoning. But benzodiazepines are different. even if you happen to overdose, overconsume those drugs mistakenly or purposely, you'll be able to reverse the action with the drug flumazenil. Yes, this flumazenil is the same drug that is used in acute alcohol poisoning or methyl alcohol poisoning. They're going to bind to the benzodiazepine receptors and prevent further action of sedative and hypnotics. However, you cannot give flumazenil via oral route. The only possibility of the route is IV. So you will have to give this drug IV route via IV route. If you give this drug via oral route, it will undergo extensive first pass metabolism and you will not be able to achieve that antagonist effect. Now here we have few of the benzodiazepines which are known for their superior benefit over a particular section of clinical aspect. For example, alprazolam, besides having all those sedative and hypnotic property, is able to have little bit of antidepressant property, which is a typical feature. So despite of being sedative and hypnotic, you can also use in a patient who are having depression. Clobazam, also sedative and hypnotic, but can be used for management of epilepsy. Clonazepam is also sedative and hypnotic, but it has a strong muscle relaxant property. Lorazepam, also sedative and hypnotic, but will produce retrograde amnesia. Triazolam, another sedative and hypnotic, but will produce psychiatric disturbances. Now this drug triazolam has been asked frequently in MCQ. Which of the following sedative and hypnotic produce psychiatric disturbances? So the answer is triazolam. Flunitrazepam to produce anterograde amnesia. This is the drug that you mix in drinks so that you can take advantage of the particular situations. Mix this drug during anesthesia to produce anterograde amnesia, because these are drugs that will prevent formation of new memories. Retrograde amnesic drugs will wipe out the old memories. Flunitrazepam-like drugs will wipe out the new memories. It will not allow new memories to be formed. And it is also tasteless. So you won't even notice you're consuming a different alcohol, a different drink. Midazolam, popular drug to induce during anesthesia. It has a strong BZ2 action. What is BZ2? We'll come to that later, but it has a strong selectivity for BZ2 receptor. Temazepam, commonly used for management of insomnia. Now the new section, that is non-benzodiazepine group of drugs. So we talk about barbiturates, we talked about benzodiazepines, and now we are with non-benzodiazepines or newer hypnotic drugs. Now, as we advances towards newer drugs, we leave behind the adverse drug reaction of the older drugs. And also, with advancing in newer drugs, the drugs become more and more selective and purpose specific. Like these drugs are BZ1 selective. BZ1 is for inducing sedative and hypnotic action, mostly for insomnia cases, but BZ2 is associated with conversions to produce memory loss. So any drug which is BZ1 specific is targeted to produce sleep, to induce sleep. It is not targeted towards loss of memories or to produce muscle relaxation. So these BZ1 specific drugs are devoid of muscle relaxant property. They are devoid of amnesic actions. And they are more selective towards insomnia, hypnosis, and as a sedative. Similarly, we have drugs, but a little bit longer acting ones are zopiclone and esopiclone. And BZ2 specific, like clobazam, they are more focused towards producing muscle relaxation, to produce amnesia also, but they are not focused towards producing sedative and hypnotic action. Now another drug which is neither belongs to barbiturates nor belongs to benzodiazepines nor it belongs to newer hypnotic non-benzodiazepines. This drug is ramilteon. Now the name of the drug itself says the mechanism of action of ramilteon, that is receptor agonist for melatonin. Now this melatonin is a hormone of pineal gland. It does not increase the duration of sleep, but it increases the depth of sleep. Means you're sleeping with high amount of melatonin, your friends enter the room, will kick you, but still you will not wake up. That is the depth of sleep. So ramilteon is a drug which mimics the activity of melatonin, that enhances the depth of sleep, not the duration of sleep. Partial agonist of serotonin, that is buspirone. Here it is a sedative and hypnotic, but it has less sedative action, less likely to produce dependence. But it comes with a disadvantage, and that is it is going to take 2 weeks for this effect of the drug to be seen in the patient. So for 2 weeks, you will have to prescribe some other sedative and hypnotic. Or you will have to convince the patient that after you take this drug, you have to wait for 2 weeks for the effect to be seen. So that is what a partial agonist buspirone means. It does not take you so high that you become excited. It does not bring you so down that you go into depression. It keeps you somewhere in between the depression and excitation phase. Now another is paraldehyde. It is also a sedative and hypnotic, but here the important part of this paraldehyde is that you cannot keep this drug in a plastic bottle, because this is going to dissolve the plastic bottle. You will have to keep it in a glass bottle. And mild form of sedative and hypnotic, but something that is easily available over the counter antihistaminic drugs that you generally take for cough and cold, diphenhydramine, promethazine. The moment you take this drug, your cough and cold will go away, but you'll still be a little bit dizzy and drowsy at the same time. Okay, now coming to the question and answer round. Kushal Acharya, are you there?
Yes, sir.
So GABA A is a
Uh, I think both, sir.
if it was GABA, then the answer would be both. But if it is GABA A, then Ganesh, Ganesh Jaisi,
Yes, sir.
GABA A is
Ionotropic
yes. So if the question was just GABA receptor, then the answer could be both because GABA A and GABA C they are inotropic receptor, whereas GABA B is a metabotropic receptor. But if the question is directly GABA A, then the answer is inotropic receptor. Sonam Kumari, absent.
Yes,
Sonam,
sir.
okay. The answer is Pratik Karki.
sir.
The answer is
Fluoride ion.
yes, chloride ion. Sudeep Pandey, absent. Nikat Praveen, she's also absent. Megha Swaraj,
Yes, sir.
the answer is
It limits the activity of GABA.
huh? Which one? 1, 2, 3, 4.
The one.
No. The answer is facilitate the activity of GABA. Diazepam belong to the category benzodiazepine. If it was barbiturates, then at high dose barbiturates can mimic the activity of GABA. Since it is benzodiazepine, it only facilitates the activity of GABA. Tanya, Anish Paudel,
Yes, sir.
the answer is
Short half-life.
no. The answer is long half-life. Because although diazepam's half-life is 8 hours, the metabolite that it forms, this methyl diazepam and then oxazepam, their half-lives is 60 hours and 6 hours respectively.
Yes, sir.
Sushil Oli.
Yes, sir.
Answer is Sushil.
One, sir.
उठी सके आओ
Barbiturate.
उठी सके आओ
Yes, sir.
Answer is
Barbiturate, sir.
diazepam overdose can be managed with flumazenil, which is an antidote. Barbiturate does not have antidote. It does not have an antagonist drug. Only benzodiazepines they have antagonist drug, and the drug is flumazenil. So tine rasos जस्तो लाग्यो. Now here we talked about a drug that is thiopentone, which is one of the barbiturates which is still currently used. But we call this drug ultra short acting and therefore used as an inducing agent because of rapid redistribution. And this rapid redistribution is because this drug thiopentone has the word thio, which stands for sulfur. Sulfur makes the drug lipid soluble, due to which it is easily able to cross the barriers like the blood-brain barrier. Now, if the drug did not have sulfur or if it was not lipid soluble, giving the drug via intravenous route will make the drug stay in the vascular system. In the picture you can see the red color, which represents that drug is distributed in the blood vessels. It has not been distributed to the tissues. But the moment drug becomes distributed by being lipid soluble, you'll find that the drug quickly leaves the body, quickly leaves the blood vessels and enter the tissues. Similarly, thiopentone sodium also, being a lipid soluble, it quickly leaves the blood vessels, enters the brain, produce anesthetic action, sedative action for a short period of time and leaves the brain, enters the blood vessels and then is redistributed throughout the body. Now, if the thiopentone reach the fingertips, if the thiopentone reach the thigh or the toes, then it does not have any particular action in those areas. Therefore, even though the drug may remain in the body, it will not have any sedative hypnotic action because that drug has undergone redistribution which has led to termination of its action. Now here we have some of the differences between barbiturates and benzodiazepines, which you can go through it later on. We have some of the drugs which are used clinically like chlordiazepoxide, diazepam, lorazepam. So with this we finish our topic sedative and hypnotics. Is there any question that you would like to ask?